Welcome to the Neuroblastoma Parent Global Symposium. My name is Leona Knox from Solving Kids Cancer, and I am also the parent of a child who had neuroblastoma. I will be moderating this panel discussion where we are being joined by Dr. Ami Desai, Assistant Professor of Pediatrics, University of Chicago Comer Children's Hospital, Dr. Cormac Owens, Consultant Pediatric Oncologist at Children's Health Ireland of Crumlin, Dr. Stephen Dubois, Director, Experimental Therapeutics at Dana-Farber, Boston Children's Cancer and Blood Disorders Center, and Professor Thorsten Simon, Clinical Director of the Department for Pediatric Oncology and Hematology at the Children's Hospital of the University of Cologne. Thank you for joining us. Before I hand over, I'd like to draw your attention to the Q&A button at the bottom of the screen where you can submit questions during the session for the speakers to address. If the button is not showing, just tap or hover your cursor to bring it up. If you see a question there that you like, give it a thumbs up to move it up the list. And I think it would be a good place to start with some questions we had from the previous section where Dr. Desai outlined neuroblastoma and just a quick overview of the disease. So Dr. Desai, maybe starting with you, why is it that some patients' tumours are or later become MIBG non-avid?
Right, so we know that the majority of patients, about 90% or so plus, will have MIBG positive disease, and there is a chance that this may change in the setting of relapse. And there is a small proportion of patients that do not have MIBG positive disease. This just, and again, if others on the call want to correct me or chime in as well too, has to do with just the catecholamines and the neuroblastoma tumors itself. I will let others chime in.
I can jump in as well. We did an analysis through the Children's Oncology Group, which here in North America is our large cooperative group spanning over 200 hospitals. And we were able to analyze the group of patients who have tumors that are MIBG non-avid, meaning they no longer accumulate MIBG, and we were able to show that those patients seem to have more favorable outcomes, but interestingly are enriched for having MYC amplification in the tumors, which we usually associate with being an unfavorable feature. But what we think is happening is that these tumors maybe are a little bit less differentiated, maybe look less like typical neuronal structures that make up neuroblastoma. And so if they maybe don't make some of the transporters that more mature neurons make, maybe they lose the ability to accumulate MIBG.
Thank you. A question on FOX2B. Can immunochemistry be strongly positive and then become negative after induction chemo? And what does that mean? Anyone like to volunteer?
So I suppose in general, we see response to chemotherapy, and I think it's very difficult to make decisions based on immunochemistry in children who've received a significant amount of treatment. I mean, we would expect to see a lot of necrosis or cell death in the tumor or the tumors that have received the chemotherapy. So interpreting the loss of an immunohistochemical pattern, I think would be very difficult post-treatment. We don't really rely on the staining so much as the architecture and what the cells look like. Are they whole cells? Are they showing signs of replication, which is a much more fundamental cellular process rather than the signal that they're expressing after they've received chemotherapy. And usually we're much more interested in the cell death and the number of cells that are still alive. Have they been able to resist the treatment rather than a particular staining test? And we would hope with modern technology and diagnostics that the genetic signal of what's left might be more relevant rather than the particular cell surface marker.
Thanks, Cormac. Anyone else like to comment, or will I move to the next question? Perfect. So 2 questions about prognostic factors. Can you speak about response to induction as a prognostic factor? And the second one, why is chromosomal aberration a prognostic factor in the intermediate risk cohort, but not stated in the high risk group? Is it to determine the course of treatment for the intermediate group?
I think I can tackle the first part, again, using an analysis that we completed through the Children's Oncology group, where we looked at response to induction chemotherapy and looked at predictors of response to induction chemotherapy. But of course, we were also interested to understand outcomes according to differential response to induction chemotherapy. And not surprisingly, patients who have a more favorable response to induction chemotherapy have more favorable long-term outcomes in high-risk neuroblastoma. So patients who have a complete response at the end of induction do better than patients who have less than a complete response. Patients who have a partial response to induction chemotherapy do better than patients who have less than a partial response. We've also been doing some work looking at the MIBG score. So how much of the total body is lighting up on an MIBG scan at the end of induction to try to understand if there's a particular cut point that can differentiate patients at the end of induction between those who are likely to do very well and those who are likely to do less well.
Maybe I'll take the second bit, which is a great question and pretty complicated. I think
that's why I took the first question.
So I think I'll try, maybe the easiest way to understand it is if you look at the high risk disease group at the minute, what we know in terms of trying to predict outcome, the stage, the age, and the status of the MICN oncogene are definite predictors, and we know that if you ignore them or if you go with them, that you can impact outcomes based on those three factors. And if you try to look at other factors such as chromosomal changes, they don't seem to have as much impact on outcome when you have those other three big factors in play, because it's not just one factor, it's a myriad of factors that lead to aggressive behavior of the tumors. And so in the setting of metastatic disease, the metastatic spread is the thing that probably trumps everything. The MICN status is a surrogate for a driver that predisposes to metastatic spread, and the age is the thing that we hope biology helps to turn off the disease in younger children. In the setting of a localized tumor, you don't have metastatic spread, and less frequently you see MICN amplification than in the setting of metastatic disease. So we're then looking for other discriminating features. And in that setting, chromosomal changes are much more significant in the absence of the other three big factors. So of course, we would love to be able to develop a full roadmap to why any individual child with neuroblastoma has a predicted outcome, but we're using relatively crude tools because ultimately we don't have the treatments available that can change things on the basis of an individual gene or an individual couple of genes. So we're still learning what all of these changes mean, and hoping that with time and collaboration that we can start to impact things in a more meaningful way. We know why they're bad, but we're struggling to be able to do something about it.
Thank you.
And I may just add it's hard to use a factor that's present in almost all patients to differentiate between patients, right? So in the high risk group, we understand that most of those patients are going to have what we call segmental chromosomal aberrations, where just part of the chromosomes are abnormal. And so if most of the patients have that, you can't then it becomes really challenging to use as a stratification tool. Whereas in the non-high risk patients, it's a much more heterogeneous group, some with those segmental chromosomal changes and some without.
Perfect, thank you. We have some questions coming in on the Q&A box now. Thank you, everyone. But if I may, I might just ask a question on behalf of the entire neuroblastoma parent community. Do we know why this disease starts? Or is there any research going on? Are we any closer to finding out what the causes may be? And one of the things that is linked to that we all feel as parents is the guilt associated with the diagnosis. So maybe Dr. Simon, I'll start with you on that one, if you don't mind.
At least we don't know any particular reason why a few kids get this nasty disease and many others not. There are different analyses have been published, but it's very difficult to analyze because of the low incidence and the millions of reasons. And there are many reports on smoking, on hair dyeing, and so on. But at least there is no reason to feel any guilt. And I mean, it's a complex mixture of reasons, but I think humans are far away from understanding what makes the neuroblastoma grow in a kid. And the young children don't have long exposure to the environment. So even if they would live in very bad conditions, to the best of our knowledge, it doesn't play a role in the development of neuroblastoma. So finally, there's no reason for guilt. This is not in our hands.
Thank you. Okay, so questions on specific treatments. First one that I have on my list is, would you recommend skipping transplant? Many parents on Facebook seem to have strong opinions that MSK-CC oncologists have the correct approach. How strong is their data supporting their conclusions?
I can start and look to my colleagues to support me in my comments. So I think in clinical medicine, we think about level of evidence and what studies are supporting our clinical practice. And the gold standard, the gold standard is really a randomized phase 3 clinical trial where half of the patients are assigned to what is viewed as current standard and half are assigned to receive something that we think and hope might be better. And so there have been 3 randomized controlled trials that have demonstrated that high dose chemotherapy with stem cell rescue, what we call transplant for short, improves outcomes in children with high risk neuroblastoma. In fact, a more recent clinical trial from the Children's Oncology Group showed that doing 2 transplants is better than giving 1, which I think lends even more support to the idea that high dose chemotherapy with stem cell rescue has a real role in this disease. I think I can speak for all of us when I say none of us like that, that stem cell transplant is a difficult modality that has some short-term and long-term side effects. But at the same time, we understand that it has been shown time and again to cure more kids. And so that's the reason that it's viewed as a standard of care.
I think maybe the other way I like to think about it is, I completely agree with Steve. Mechanistically, we're trying to do something different. When we start off with treatment and conventional chemotherapy, we're trying to get control over the disease. We're trying to get rid of as much of it as we can, because it's causing the kids to be very poorly, to feel very unwell, to have lots of pain, and the other symptoms that they present with. And so to start off with that chemotherapy, that's the initial goal. And there's a point that you can go to, that you can push the kids to go through. with that type of chemotherapy. But at some point, it's not enough. And we know this. We know that if you don't do something else after conventional chemotherapy, the disease will either still be there or it will come back. And you can keep giving that intravenous chemo over and over. It will stop working at some point. And so you need to do something different. And the reason that the disease or some of it is still there or going to come back is because it has developed resistance. And so the idea of the high dose chemotherapy is to overcome this resistance in one go with different agents, and in a different way of doing it. And by overcoming that resistance with the stronger doses, you're doing something different to try to build on where you were before. And I think COPEN's approach would mirror the COG approach. It's slightly different medicines, but very similar blueprint. And our feeling is that by alternating the different types of treatment, starting with the induction chemotherapy, followed by consolidation high-dose chemotherapy, with a surgical intervention, radiotherapy and immunotherapy, you're challenging the disease in different ways that are hopefully complementary, hopefully minimizing the toxicities that would be additive if you kept going in the same manner, and not giving the disease a chance. And so theoretically and mechanistically, to me, I think that's a very important reason to do it.
I mean, a big concern of parents is that the risks overweigh the benefits, and that we might give the neuroblastoma cells back during the transplantation procedure. But at least the statistics we have clearly show that the benefits overweight the risks, and these survival curves are very stable. So if you look at the same population years and years later, you'll still see that there is a survival and cure benefit for those kids who underwent stem cell transplantation. So what kind of treatment should I recommend? I would recommend the better one. And there are kids who had no high dose and transplant who survived, but this is less likely. So that's why we would recommend high dose chemotherapy with stem cell transplant.
Thank you. And do you think in this age of immunotherapy that there is space for that thinking to change, even if it hasn't changed already, about high dose chemotherapy?
I mean, the cure rates are not 90% or 95%. So I think I wouldn't thinking about changing. I would think about combining, and it's a dangerous experiment to take away one element which has been proven to be effective, hoping that it's not necessary. So this would be a very complicated clinical trial, which is, I think, is not planned yet, to my knowledge.
Thank
But
you.
I think it's a fantastic question, Leona. I mean, I think, as I said in my remarks, we'd love to not do transplant, but we've shown time and again that it's effective for these children. Now, those studies were conducted, before the era of chemoimmunotherapy, which is really changing the field. That's the combination of conventional chemotherapy together with anti-GD2 monoclonal antibodies. And so I think we need to see over time and study very carefully, as Dr. Simon said, whether that still holds true, as we've made progress maybe in improving our induction chemotherapy. Is that still the case? But it needs to be studied very carefully.
Sure. Thank you. So along the same kind of topic, what about the possibility of earlier diagnosis? Are there any ways to find this disease in a child earlier before it has progressed much? And following on, could that impact outcomes if it is detected earlier?
Detecting earlier it's two questions. So the neuroblastoma screening programs did show that very early screening doesn't reduce the rate of high-risk disease. So routine screening has not been shown to be effective. And The other question to detect earlier, it's a question all parents ask. Could I have been at the doctor's 2 weeks earlier? But it's so rare, so it takes a while for the pediatrician and for the parents, for the pediatricians to realize that there is a serious condition with their child. And also, we mostly see kids with quite large tumors. So children tolerate a lot, so they don't have so much symptoms, and we even have incidental detection of large neuroblastomas. So it can drive parents mad to think about earlier diagnosis, but I think it's not realistic. And it's the same like my first question. It's not the fault of the patient, of the parents, if they don't realize early enough that the kid has cancer. And I think every parent come to the doctor early enough.
I think all of us would agree on this call that this is a question that comes up when we meet new families all the time. And the way I like to explain it to families too is that I think of neuroblastoma as being very driven by the biology of the tumor. And it's very different than adult malignancies, which may be impacted by exposure and environmental exposures and other things, and where clearly screening has improved outcomes for certain types of adult malignancies, but it's not the same so much in pediatric malignancies, and particularly a cancer such as neuroblastoma. We did briefly go over some of the screening studies that were done with urine catecholamines in infants in Japan and Canada and I believe Germany as well too. And with the early screening programs, what was being picked up were the tumors that had favorable biology or would have regressed on their own. And it was essentially in some cases causing more harm than good by intervening in cases where there maybe didn't need an intervention. And so I guess the short answer of it is I think if a tumor is going to be high risk, it in many ways is going to be high risk, is sort of how I simply like to look at it. But again, open to other people's thoughts, but I think it's just very different than adult malignancies and the way we think about it.
I completely agree with what's been said. I guess the big problem is that children present with symptoms that are very vague and could be anything. And if you think about how children with neuroblastoma present at the very beginning, maybe a bit of constipation, maybe they're feeling a little bit off, things unfortunately that are very common in the family doctor or in the emergency department. And unfortunately, it relies on an abnormal index of suspicion or somebody. So if I'm working in the emergency department doing a moonlighting shift and somebody comes in and starts complaining of tummy pain, I'm thinking, oh, we have to do a scan or we have to do something, because that's what I spent all of my time doing. But, neuroblastoma is like a 1 in 100,000 children per year type event. It's so rare. Family doctors might see it once in their career. Emergency doctors not very often, and parents hopefully never, except unfortunately the people who are affected by it. So it relies on indexes of suspicion, indices of suspicion. I think even something like the brain tumor awareness program in the UK, it's a great idea, but do people really think it's going to affect them? So they probably don't, and it relies on that abnormal aura or sense that something's going wrong. And unfortunately, it takes a long time. It's across the whole spectrum of pediatric malignancies. It's very common in teenagers with bone tumors that they ignore pain in their leg for 3-4 months. So it's certainly not a fault thing. It's one of the really unfortunate features. And of course, because it's probably there for a long time before it comes to attention, it either has spread or it hasn't. And I suppose in the children that it hasn't spread, you might be relying on tummy swelling or something to cause it to come to attention, and that's likely to be more favorable, perhaps. And if you present with symptoms as a result of metastatic disease, that's usually the state of the disease, and it's much harder to treat. So in principle, the more disease is there, the more we have to get rid of. It's certainly harder and more likely to cause symptoms for the child. but not necessarily a direct prognostic factor for how well the child is going to do. That's to do with a lot of, I think, is luck and what the innate features of the tumor are, why it started to grow at a particular time, and where it spread to, how effective the treatment is ultimately. And it's certainly not the fault of anybody. And hopefully we get to see these kids earlier and we can do something about it, but that's not even a guarantee.
Yeah.
Thanks,
We have 40% of patients who have no symptoms. We register the initial symptoms, so 40% have X-ray for infection or something like this. So there's a lot of patients with no clear or no symptoms at all.
Okay, so I think related again, another question. There are children who, despite successful upfront therapy with a complete response, go on to subsequently relapse, and sometimes very soon after upfront therapy is completed. Are there any predispositions or prognostic factors which indicate why some children relapse quickly within the first year and others may not? Dr. Du Bois.
Well, it's a great question, and I think it's motivated by the tremendous frustration that parents and patients and providers, medical providers, feel in a situation like this, where a child has done well. Maybe they've had a complete response, a complete remission at the end of induction. They go through their transplant consolidation phase. They go through the antibody phase. And after all of that, they're still in a remission. And, there's a little feeling of like success at the end of all of that, only to then, 6 months later, have the disease come back. So it's tremendously frustrating that even patients, even our very best responders can still have a recurrence. I don't think we have great tools for predicting that today. Within the high risk group, I'm really restricting these comments to the high risk patients. I don't think we have great tools for saying this is a patient who's going to respond well, but be at higher risk of having the disease come back early off therapy. We think about MICAN amplification as maybe the closest that could come to that, where we've shown that they have a favorable response to initial therapy, but remain at risk for disease recurrence. But I'm not sure that we have something so solid that we would extend therapy or have some other intervention to do for patients.
Something so solid yet, maybe. I know there's a lot of people working on this, including
Absolutely. I don't know, Ami, Cormac, Thorsten, if there's a biomarker that I'm not thinking of.
No, I
mean, there's millions of biomarkers, but they don't help at all.
Yes.
And the question is, when we identify those candidates very early, what else should we do? I mean, this is a really intensive multimodality treatment.
I think one of the things we're all trying to do, or our colleagues are trying to do, is to find ways to better, measure minimal residual disease or any sort of very little bit of disease that might be left over. Imaging is only so good, and what we capture in the bone marrow is only so good. But are there more, are there better ways to capture any sort of leftover disease that's around? And this is work that people are doing.
Thank you. Ami, you've actually moved on to another question. Have we found any more sophisticated ways to detect minimal residual disease in neuroblastoma? None of the existing methods are 100% reliable. And is this one of the main reasons why we can't prevent relapse?
Right. So I think, a lot of our colleagues are working on methods for this. either within the bone marrow or through liquid biopsies and measuring circulating tumor DNA, cell-free DNA, and trying to study this in a larger trial perspective to see if we can to find out if there are good measurements of and correlations with response to therapy and relapse.
And I may just comment on that. We're working together with an investigator at Ami's Center in Chicago to try to study in the context of our frontline high-risk trial in the COG. We're trying to study approximately 400 kids with high-risk neuroblastoma and looking at this liquid biopsy technique and looking over time in the peripheral blood, can we see markers of neuroblastoma? And of course, we'll be very interested to know, are there a subset of patients at the very end of all of the therapy where we see still evidence of tumor and in the blood, and are those the very patients then who go on 6 months later to relapse? So we'll be able to look at that in an initial cohort of 400 patients. But then if we find something interesting in that group, we'll still be collecting samples from the remaining 350 patients on the clinical trial, so we can go back and say, okay, well, we saw this in the first part of the trial, and can we validate or really confirm our findings in the second part of the trial? And we think that that's important because before we're going to use any test to make a clinical decision, we really want to have confidence in the meaning of that test. And so when we're able to validate or confirm the findings in an independent group of patients, that always makes us feel more confident. So I think that's been some of the issue, just reading the question about, well, why aren't these things being used in clinical practice fairly routinely? It's I think largely for that reason, that we don't just need data, we need really confirmed, validated data that leaves no doubt that that biomarker is going to predict a specific outcome.
The setting, it's probably easier to find out the prognostic good patients and to de-escalate treatment, because it's very, very difficult to intensify high-risk neuroblastoma treatment.
Thank you.
I think that one of the other things, sorry, Leona, about biomarkers, that ultimately what we would love is not just to be able to tell or predict a prognosis, is that we could do something about it. And that's an even bigger problem. So, just because you have circulating tumor DNA or a PCR pattern or whatever the marker of minimal residual disease is, does it mean a child is going to relapse? If you decide to treat them, does that treatment change the outcome? And I saw one of the questions, as Thorsten has just mentioned and Steve referred to as well, the amount of treatment children with high-risk neuroblastoma get is incredible in terms of intensity. And just because we have other treatment doesn't mean we should give it unless we have proof that it's going to make a difference. And I think, so hopefully biomarkers are a way that we might be able to generate that proof. And I can appreciate that it's probably monumentally frustrating to people to think, well, why can't you just do it? It's because of the stakes and the proof that's required. It's a tedious, painstaking process, but we have to do it in this way to prove that A, the biomarker is relevant, and then that if we do something different, that the biomarker changes in a way that we can interpret, and that ultimately the children do better, because otherwise we are going to subject children to extra treatment for no benefit at all for that child, and that is not acceptable. So it's really challenging, it's really frustrating, but it must be done correctly. And Steve's study that he's outlining and others are really important to prove the concept first as a first step, and then hopefully we can build on that quickly.
Thank you, Cormac. And I can definitely say that there is huge frustration and everyone wants it to happen quicker, because of what our kids go through and the terrible outcomes that many face. And do you think there is enough joined up working on this type of work so that we can get to the answers quicker? I mean, there's significant collaboration within the neuroblastoma community? Do you think it's enough to do what we need?
My feeling would be at a biology laboratory level, there's huge cooperation. I don't think there are any barriers amongst the scientific community in terms of developing these techniques and validating them and cooperating with each other. I think that's a standard. That's a daily occurrence. I think it's very easy to see that if you look at the way people work with each other and share their data. There is no agenda. There's no hidden monetary gain or anything like that. It's a very open thing. I think the problem is when you start to introduce it into clinical treatments. And it's not because of a lack of willingness to work together. It's because we're treating children, and the rules around treating children are different in all countries, and the levels of bureaucracy that are involved in opening clinical trials across the world are high, and in Europe they've gotten even harder with the new GDPR regulations. I think we're trying to fix that. I think we're in great dialogue. I think the COG and COPEN and now with GPH in COPEN are coming closer and closer together in terms of what we want to do. We have a great dialogue and are proposing a transatlantic trial in the very near future, and hopefully we can build on that. And I do think it's coming. I appreciate that parents think it's not happening fast enough. It's a really difficult thing to do, but we're working on it, and I'm optimistic that in the coming short years, although that seems like a long time, we will get much better at it. And I think with SKC kicking us in the butt behind, I think that's a great impetus, and I think a great facilitator.
Great, that's
And
good.
Leona, I may just pick up on that. I mean, I think as Cormac said, when we put these clinical trials together, it's a tremendous effort to do. And so I just say, tremendous gratitude to the parents who have the courage to put their children on these clinical trials. I mean, we spend years thinking about these trials and what's going to be in the best interest of the patient, what's going to advance the field scientifically, both in terms of the treatment, but also in terms of some of the biomarkers that we're talking about. And so, but we can't get these trials done, obviously, if patients and families are not participating. So I'll just, that hasn't been said yet, and it's really critical, and we're grateful for every single enrollment to our clinical trials.
Thank you, appreciate that comment. In the interest of time, we've still lots more questions. I'm thinking that we can maybe try and address some of these after this webinar in different ways, but maybe we could do some quick fire questions as they're coming in. What about the role of surgery? Does it matter to have a tumor completely removed versus partial?
This is the issue for a short answer. Nobody really knows, but it's probably worth to do the best operation possible.
For a high-risk trial. For a
high-risk, yes. High-risk.
Yeah.
But even a low risk.
Thank you. Have there been any comparative studies on which anti-GD2 immunotherapy regimens are superior in outcomes?
No, that's an easy answer. I mean, I think it's definitely something we'd like to do. I think we know a lot of information about the tolerance of the treatment, but there have been no trials yet on matching one up against another.
But you said it's something you would like to do. You think it's possible? It could be done? Or
personally, I'm not sure it should be done. I think it's something we need to discuss, but I guess one thing I would be worried about, do we really think there's going to be a huge difference in the type of the antibody, and how much time would it take to prove that? That could take 5 or 10 years, and perhaps we're better off going for bigger changes like combining chemoimmunotherapy upfront in frontline disease rather than doing a dinutuximab versus dinutuximab beta versus naxitamab trial. I think that I'm not sure the children and the families would get the value out of that. I think it could take a long time, and we might get much difference. So personally, I would push for different trials.
Thanks, Cormac. Is it possible to have an MIBG avid and a non-MIBG avid tumor in the abdomen at the same time, i.e. two separate tumors?
Yes, that's possible. We see that not infrequently. We consider those patients to be MIBG avid, if at least in the children's oncology group, if at least one of the one tumor is avid or lighting up on an MIBG scan. But we know that there's heterogeneity with some areas that are either frankly non-avid, meaning totally negative on the scan, or that there's lower uptake in some tumors, and we don't fully understand that.
Thank you. And should neuroblastomas be tested for GD2 expression before being given anti-GD2 antibodies or other therapies, given that occasionally GD2 expression is low or negative? What are the challenges?
We don't know the threshold. That's why we don't test the tumors. We're doing GD2 staining in bone marrow and see very different levels of expression, but at least we have no alternatives for GD2 treatment, so we don't stop treatment when we find a low expression.
I think the other thing that is very important to consider and think about is the immune system's response to treatment. And we know that some people don't mount the response, some children don't mount the response that you would want when delivering anti-GD2 treatment, and that has been shown in retrospective studies to influence outcome. And so I think that's something we need to work on moving forward, not just about the anti-GD2 expression, because that could be very variable in different tumors, and you can't go testing every site of disease in the body, but rather I think focus on the child's immune system response, the KIR ligand response to the immunotherapy, and that might be a better way or a more meaningful way of doing it. But that has to be tested in a prospective way, because again, if you're going to change treatment, you need really strong evidence that would make a difference and not result in under-treatment and worse outcomes for some children.
Thank you. This may or may not be the last question we get to, but I think it's a really important thing to families. And Amy, you mentioned this in your talk about predisposition. How high is the risk of another child of the same family developing neuroblastoma? Does it run in the family generation? Supposing the neuroblastoma patient cannot be saved, why then proceed with bone marrow transplant? Sorry, that's running into a second separate question, which we've kind of addressed. But in terms of siblings and risks of future pregnancies, could you speak to that?
Right. So just for everyone on this, on the panel as well, too, we spoke a little bit about familial neuroblastoma and germline ALK and FOX2B mutations, and you know, how there's a concern if perhaps there's multifocal neuroblastoma or bilateral neuroblastoma, or things can be inherited, things can happen de novo in a patient for the first time. I think if there is a germline finding for a patient, it would be reasonable to have you know, the family tested. And then I also mentioned some other syndromes that may be associated. So if you are in sort of that higher risk category where there is a germline syndrome within the family, it is worth getting the family tested. But the vast majority of patients do not have a predisposition, a germline predisposition or inherited predisposition to neuroblastoma. So it just really affects a small proportion of patients.
It's 1% familial neuroblastoma, approximately.
Perfect. Okay, so thank you, everyone. That's been a really important and great discussion, I think, really insightful as well. Sorry we didn't get to all the questions. Up next, after the break, we have targeting ALK discovery to frontline treatment and dealing with a childhood cancer diagnosis. Head back over to the watch page now to get prepared. Thanks, everyone.
Thank you.
Cheers.